Now, how we can diagnose the thalassemia? So, we have pretest probability from which we can suggest the type of thalassemia. So, if the presenting patient is infant, which is usually 6 to 24 months, so we can consider beta thalassemia major because in infants after the 6 months of age, the fetal hemoglobin is declining and the patient presents with the symptom of thalassemia. While in children who are usually aged 2 to 6 years, so we can consider beta thalassemia minor or alpha or beta thalassemia intermediate form. On the basis of demographic features like family history of thalassemia and Asian, African, or Mediterranean ancestry, we can also consider and can think about the type of anemia. We can also have incidental finding like microcytic hypochromic anemia not explained by other causes or not responsive to supplemental iron. Antenatal ultrasound showing hydrops fetalis and detection of abnormal hemoglobin chain in newborn screening. Family history also play an important role in diagnosing patients with clinically silent thalassemia. Consider the possibility of minor form or traits if the family member is diagnosed with a more severe form. What are the initial investigations? So, initial investigation like CBC, which is a complete blood count. What will be the characteristic finding? We will have microcytic hypochromic anemia, MCV less than 80, while MCH less than 27 picogram per cell. MCH is mean corpuscular hemoglobin, which is the average mass of HB and RBC, which range from 25.4 to 34.6 picogram. So we will have MCH decreased, MCB decreased, and these can present regardless of the HB level. Other red cell indices, we will have normal REW, while we will have higher RBC count than iron deficiency anemia. Menzer index, so it's the ratio of the MCV by RBC used to differentiate between thalassemia and iron deficiency anemia. If the ratio is less than 13, so it suggests thalassemia, while a ratio greater than 13 suggests iron deficiency anemia. Hemolysis evaluation, so it's non-immune mediated hemolytic anemia. We will have decreased heptoglobin, increased LDH, and increased retic count in response to the hemolysis. In liver chemistry, we will have hyperbilirubinemia, which will be indirect, unconjugated hyperbilirubinemia, and Coombs test will be negative because it is non-immune mediated hemolytic anemia. Iron study, particularly ferritin, expected to be normal or elevated in thalassemia, while in iron deficiency anemia, ferritin level is low or can be normal or elevated, but usually it's low in iron deficiency anemia. Then on the peripheral smear, we will have target cells, teardrop cells, anisopoic erythrocytosis like the RBC of different size and shapes. We will have HPH, inclusion bodies, and erythroblast. CBC parameter can help differentiate between thalassemia minor or rare from iron deficiency anemia, which is frequently associated with a high REW, low RBC count, and low MCV, typically occurring once HP is less than 10. In thalassemia, microcytosis is always present, regardless of the HP level, and RDW is normal to increase. Also, RBC count is higher and MCV is lower than iron deficiency anemia. Low ferritin suggests iron deficiency anemia and patients should receive iron supplementation. Suspect thalassemia if there is no significant response after 3 months. What are the confirmatory studies? So, detection of hemoglobin variants like HB electrophoresis, which is a qualitative analysis. We have automated high power liquid chromatography, which is qualitative and quantitative both. Finding vary. Hemoglobin A and subtypes like HbA2 values are helpful to determine the diagnosis. To distinguish alpha from beta thalassemia, and HbE may be elevated in some children and adults with thalassemia. Now we can interpret the findings of the electrophoresis. So, an alpha thalassemia and beta thalassemia, alpha thalassemia minor and intermediate are HPH disease. MCV or MCH will be normal or low, it will be low, it will be low. So, MCV or MCH usually low in all forms of thalassemia, while HbA2 is elevated in beta thalassemia and HbF is also elevated in beta thalassemia, while these are normal in the alpha thalassemia. So you can differentiate easily between alpha thalassemia and beta thalassemia if they have given that the patient has high HbF and HbA2 level. Genetic study like PCR is used to determine the specific diagnosis and mutations. Bone marrow aspiration not routinely indicated. Beta thalassemia minor should be strongly suspected if HbA2 is greater than 3.5%. We can also do imaging. They are not routinely indicated but can be used for the suspected craniofacial abnormalities and extramedullary hematopoiesis. Skull X-ray. So what will be the finding in the skull X-ray? We will have high forehead, prominent zygomatic and maxilla referred to as chipmunk faces, and hair on end appearance known as crew cut sign. This is the hair on end appearance in the skull, which show the expansion of diploic space with thickening of trabeculae, and it is the result of the extramedullary hematopoiesis. The hair on end appearance produced can also be seen in other chronic hemolytic anemias. We also have signs on the chest X-ray, which is a rib within a rib sign in thalassemia. So it is due to extramedullary hematopoiesis in the thorax, and findings are mediastinal or pulmonary masses, and we have subperiosteal extension in the ribs, also known as a rib within a rib. An MRI spine can also be helped to elevate the mass effect due to extramedullary hematopoietic pseudotumors. Then management. So all patients, we will do patient education and genetic counseling, screening test for relatives. Thalassemia minor, so usually no treatment required. Folic acid supplementation may be indicated during pregnancy or acute infections. Thalassemia major and intermediate forms, so transfusion therapy, erythrocyte concentrate is given. Indication is HB less than 7 or more clinical symptoms, and the target to keep the HB level is greater than 9 to 10 gram per deciliter. Surveillance and treatment of complications. So iron overload disease, we give chelating agent like Diffracerox, indicated when iron accumulation reach toxic level. When the ferritin level greater than 1000, so greater than 1000 microgram per deciliter, so we give iron chelating agents. What are other complications like gallstones, asplenia, and extramedullary hematopoietic pseudotumors? And in selected patients, we can do splenectomy. Potentially curative treatments are hematopoietic stem cell transplantation and gene therapy. Complication of thalassemia, maternal complication are cardiac failure, diabetes, hypothyroidism, hyperparathyroidism. These all occur due to iron accumulation leading to secondary hemochromatosis. And in fetus, we have growth restrictions, prematurity, and transmission of hepatitis B, C, and RHIV. So these are all complications which result from the iron overload, hypoxia, and the hypoxia in thalassemia is either due to intramedullary hemolysis or extravascular hemolysis. And also there is a high affinity for the oxygen, so oxygen cannot be delivered to the tissue. So thalassemia leads to all these complications as well. Thalassemia in special patient groups like thalassemia in pregnancy. So most patients with thalassemia suffer from infertility due to gonadotrophic hypogonadism, which occur due to hemosiderosis, and they require assisted reproduction technology to achieve pregnancy. Spontaneous fertility may occur in patients who have successfully undergone iron chelation and blood transfusion. Pregnancy in patients with thalassemia should be planned as they are considered high risk for both mother and fetus. Preconception, genetic counseling, close antenatal monitoring, and screening, intrapartum and postpartum management are highly recommended. A multidisciplinary team including hematologists, cardiologists, endocrinologists, and gynecologists should be involved in the management of pregnant patients with thalassemia. Fertility assessment and management. Screening for thalassemia, hemoglobinopathy screening should be offered to women with unknown hemoglobinopathy status and normocytic or microcytic anemia. Partner screening for thalassemia carrier status. If the partner is not a carrier of thalassemia, so follow protocol for spontaneous conception, ovulation, induction, like gonadotropins, clomiphene citrates, or IVF, in vitro fertilization. If the partner is carrier of alpha thalassemia, so offer pre-implantation genetic testing and IVF. If partner has thalassemia trait, so advise patient to use donor gametes or sperm donor. If both partner have thalassemia or thalassemia trait, so offer genetic counseling prior to conception. After successful conception, the fetus will undergo thalassemia screening using chorionic villus sampling, which is done usually 10 to 13 weeks, or amniocentesis, which is done after the 15 weeks of gestation. If both partners have thalassemia major, so consider alternative including adoption. Preconception screening and review. The most important factor to consider during a fertility assessment are cardiac and liver function and risk of vertical transmission of viral diseases. Antepartum screening, so evaluation, cardiac function test, gestational diabetes screening, 16 week of gestation, and fetal growth monitoring, serial fetal biometric ultrasound starting from 24 weeks of gestation. Assessment of splenomegaly. Iron chelation treatment should be adjusted and closely monitored during pregnancy. Deferoxamine should be used in second and third trimester, while defraserox and defriprone must be discontinued 3 months prior to conception. Transfusion should aim to maintain HB greater than 10 to prevent intrauterine fetal growth restriction. Then we have intrapartum and postpartum management. So vaginal delivery is possible. Patients usually require cesarean, as those with thalassemia have an increased incidence of cephalopelvic disproportion, so the fetal head cannot pass through the normal diameters of the pelvis. Breastfeeding should not be discouraged. Resume iron chelation therapy if eligible. Deferoxamine can be resumed immediately postpartum. Use of defraserox and defriprone should be delayed until the patient has stopped breastfeeding. Continue calcium and vitamin D supplementation, thromboprophylaxis with low molecular weight heparin, discuss contraception option, progesterone only pill or barrier method. So that's all about thalassemia, thalassemia types, alpha, beta, and thalassemia in pregnancy.